Hi guys, welcome to this session of surgery LRR for INI-CET. So let's start. This is your surgery faculty Dr. Pritesh Singh. Welcome and happy Diwali in advance to everyone. So let's start the questions. See the first one. If you see the first question, a 45 years old man with refractory peptic ulcer disease, see the problem. Patient is having refractory peptic ulcer disease is being considered for surgical intervention, right? Which of the following procedures will most likely preserve vagal innervation of gastric antrum and pylorus while reducing acid secretion? Guys, I am waiting for your reply. Anu Sharma, Rise Uppan, tell me. Here we have to perform vagotomy, but we have to preserve the vagal innervation of the gastric antrum and pylorus. Yes, very good. One person, Sagufta Khanam, Dr. DSK. So guys, see here, it's very easy to understand. You can see this. This is stomach and you can see the vagus nerve. This is the vagus nerve, right? This is the left vagus which is anterior. What is the first branch? You can see the first branch is this hepatic branch, and you can see this is the right vagus. Right vagus is posterior. The first branch is CNG. What is CNG? That is criminal nerve of Grassi, and this one is celiac branch. Celiac branch. So you know that what is this highly selective vagotomy whenever we are going to divide these seromuscular branches. So if you just divide these seromuscular branches, this is highly selective vagotomy. And in highly selective vagotomy, you can see here the nerve supplying the gastric antrum and pylorus, that is nerve of latter jet, that is spared or preserved. So nerve of latter jet, that is spared or preserved. What is selective vagotomy? In selective vagotomy, we have to divide the vagus after celiac and hepatic branch. And what is truncal vagotomy? Whenever you are going to divide the main trunk. If you divide the main trunk, that is truncal vagotomy. After celiac and hepatic branch, you are going to divide the vagus, that is selective vagotomy. And if you are going to divide the seromuscular branches, that is what? Highly selective. So now everybody is correct, almost everybody. Yes, Sri Devi, Chahat, Nazia Ali, Pradeep Singh, Chahat, everybody is correct guys. We are doing what? Highly selective vagotomy. So in highly selective vagotomy, the innervation of gastric antrum and pylorus is preserved while it is going to reduce the acid secretion. So here the correct answer is D, option D. So you know that what is the other name of highly selective vagotomy? You must be knowing it is also known as parietal cell, also known as proximal gastric vagotomy. So it is going to preserve the vagal innervation of gastric antrum and pylorus. Clear? So guys, see the next question, very easy. 28 years old man presented with 3 days history of vague lower abdominal pain. You can see here. Apart from that, low grade fever. Patient is having urinary frequency. Initial pelvic examination and urine analysis were inconclusive. You can see the CT scan revealed acute appendicitis with inflamed appendix located in the pelvis. The delayed diagnosis in this case was most likely due to, guys, tell me. I am waiting for your reply. Tell me, I am waiting for your reply. Yes, here the patient is having pelvic appendicitis because CT is telling you that patient is having pelvic appendicitis. Patient is having pelvic appendicitis. Yes, almost everybody, Pallav, Pradeep, Anurag, Sri Devi, Anuj, almost everybody is correct. So here you can see that appendix pelvic location masking the classical right lower quadrant signs. Whenever the appendix is pointing towards pelvis, what happens? Abdominal signs and symptoms are not prominent. And in this case, patient might be having diarrhea, and we have to elicit the tenderness by digital rectal examination. Patient might be having urinary symptom also. Why? Because in pelvis there is ureter. So there is irritation of ureter that can lead to microscopic hematuria. There will be urinary signs. Clear? So second option is, you can see here, second option, misinterpretation of urinary symptom as a primary urological issue. This is incorrect. Lack of characteristic migration of pain from periumbilical to right iliac fossa. No, this is the most characteristic symptom. And absence of typical anorexia and vomiting in early appendicitis. This is also wrong. So what is the correct answer? Appendix pelvic location masking the classic right lower quadrant sign. So, correct answer is option A. Okay. Now, this question is very, very easy, guys. Tell me what's the correct answer? Correct answer for this one, laparoscopic surgeon is repairing an inguinal hernia. Laparoscopic surgeon repairing an inguinal hernia and wants to avoid using electrocautery in certain areas to prevent injury. Which anatomical region should the surgeon avoid? Which anatomical region should the surgeon avoid? Okay, NEET PG 25 V7H. Till now only one person have marked the correct answer. Till now only one person. अभी तक सिर्फ एक लोगों ने सही आंसर मार्क किया है. Only one person. Sky Doc SX, Anuj Sharma, very good. Anuj, very good. Guys, only one. Now 4-5 people mark the correct answer. See, why surgeon is not using electrocautery? Because if the surgeon is going to use electrocautery, what will happen? There will be injury of nerves. And you know that the area in which there will be crowding of nerves, if nerves will be injured, what will happen? If nerves will be injured, there will be, what will happen? There will be pain. And this is known as triangle of pain. So guys, can you tell me what are the boundaries of triangle of pain? Here, there are multiple nerves. 4 nerves are there. So, in this particular region, you are not supposed to use what? Electrocautery. What is triangle of doom? In triangle of doom, there is iliac vessels. So, in triangle of doom, you should not use sharp instrument. Sharp dissection should not be done. Otherwise, what will happen? It is going to cause injury of iliac vessels. Triangle of Hazelback is via triangle of Hazelback, direct hernia is coming out, and triangle of Scarpa is also known as femoral triangle. So, guys, see this, it is triangle of pain. Let me discuss, because this is very, very important. See, what is triangle of doom first? Can you tell me what are the medial boundaries, guys? Medial boundaries? Medially, there is vas deferens or ductus deferens. Laterally, gonadal vessels, apex, deep ring, and base, peritoneal edge, content, iliac vein and artery. So, in this particular region, triangle of doom, what? Sharp dissection should not be done. In this triangle, sharp dissection should not be done. Why? Because it is going to cause the injury of iliac vessels. And here you can see this is very important. This is triangle of pain. Guys, can you tell me the boundaries? Superiorly, iliopubic tract, medially, gonadal vessels, laterally, peritoneum, and what's the content? In this image, you can notice that there are 4 nerves. So, what are the contents? First, femoral branch of genitofemoral nerve. Second, anterior cutaneous nerve of thigh, also known as anterior femoral cutaneous nerve. This is lateral cutaneous nerve of thigh, lateral femoral cutaneous nerve, and this is the 4th one. Clear? So, femoral branch of genitofemoral, anterior cutaneous nerve of thigh, lateral cutaneous nerve of thigh. Now, one question for all of you. Can you tell me, out of these 4, which one is most commonly injured during laparoscopic hernia repair? Waiting for your reply. Guys, tell me, I am waiting for your reply. Out of these 4 nerves, which one is most commonly injured during laparoscopic hernia repair? It's a famous question. Most commonly, very good, very good. Bleak, Anush Sharma, very good. Hanashu, yes, Shashank, very good. Everybody is correct, almost everybody. Is the lateral femoral cutaneous nerve or lateral cutaneous nerve of thigh. This is most commonly injured during laparoscopic hernia repair. One question for all of you. Which one is most commonly injured during open hernia repair? Guys, I am waiting for your reply. Which one is most commonly injured? This is most commonly injured during laparoscopic hernia repair. Which one is most commonly injured during open hernia repair? Open hernia repair, very good. Dr. VG, very good, very good. Dr. VG, bleak blanket. So, almost everybody is correct, guys. Almost everybody is correct. It is ilioinguinal nerve. Guys, I am repeating. This is ilioinguinal nerve. Ilioinguinal nerve. There are 3 questions related to nerve injury in this area. First is most commonly injured nerve during laparoscopic hernia repair, lateral cutaneous nerve of thigh. Second, most commonly injured during open hernia repair, that is ilioinguinal nerve, and most commonly injured during appendectomy. And during appendectomy, which one is injured, guys? You know which one? It is iliohypogastric. So, during appendectomy, which one is most commonly injured? This is iliohypogastric. ileo, hypogastric. So, these are the 3 important questions which are asked frequently. Okay. Now, see the next question, very easy. Read it. 50 years old man presents with acute abdominal pain and bilious vomiting. Physical examination reveals a distended abdomen, okay, and he has not had bowel movements for the past 3 days. Non-passage of feces for the last 3 days, there is abdominal distension. Abdominal X-ray is shown below. What is the most appropriate next step? First question for all of you, what is the diagnosis? See the X-ray. Guys, see the X-ray. Tell me the diagnosis. X-ray, tell me the diagnosis. Waiting for your reply. Deepak, hunch, family man. Yes. Small bowel obstruction, very good. Guys, it is small bowel obstruction. Can you see in this case? In this case, you can easily notice, what you can notice here, that these are multiple bowel loops placed centrally, narrow in caliber. And can you tell me which bowel loops? Because you can notice here, what? Circumferential ring-like pattern. And what is this circumferential ring-like pattern? You know, this is valvuli conniventis. So, this is valvuli. You can see here, this is valvuli conniventis. So, can you tell me guys, what is this loop? If this is valvuli conniventis, what is this bowel loop? This is small bowel obstruction, plica circularis or valvuli conniventis. So, it means it is jejunum. And another question, if you can see the jejunum, where is the obstruction? In the proximal part of small bowel or distal part of small bowel? If jejunum is visible, tell me, obstruction is in the proximal part of small bowel or distal part of small bowel? All of you know it is distal part of small bowel. So, it is distal small bowel obstruction. So, where is the obstruction? In ileum. Since obstruction is there in the ileum, that is why what is visible? Here you can see jejunum is visible. So, this is a patient of small bowel obstruction. What is the problem in small bowel obstruction? You guys know. This is the obstruction. So, what will happen? The proximal part will be distended, distal part will be collapsed. And if proximal part will be distended, distal part will be collapsed here. Here there will be excessive secretion, collection of 2 to 3 liters of fluid. It leads to third space loss. And because of this third space loss, patient goes in the state of, tell me guys, because of third space loss, this patient goes in the state of hypovolemia. And since patient goes in the state of hypovolemia, what is the first step whenever these patients are coming to emergency? Whenever these patients are coming to emergency, first step we have to give IV fluid. So, what? Since patient is in the state of shock, first give the IV fluid, and after resuscitating, when the urine output is 1 ml per minute, then we take the patient for laparotomy. So, what? Administer oral laxatives? No. Start IV fluids? Yes, almost everybody marked it correctly. Immediately without resuscitation, we are not taking the patient for laparotomy and we are not giving IV antibiotics immediately. First, we have to resuscitate, and what you have to give guys? Start IV fluids. So, what is the correct answer? We have to start IV fluids. Clear? So, correct answer is option B. Okay. Now, see the next one. Very easy, and let me tell you, almost every year you are going similar questions in exam. See, 16 years old girl, intermittent abdominal pain, there is occasional rectal bleeding and pigmented macules on her lips, buccal mucosa and digits. Her mother had similar pigmented spots. What is the most likely diagnosis? Everybody is marking the correct answer. Obviously, it is Peutz-Jeghers syndrome. This is Peutz-Jeghers syndrome. Clear guys? Now see this. See, can anybody tell me what is the cause of this intermittent abdominal pain? What is the cause of this intermittent abdominal pain? Waiting for your reply. Rohit, Twinkle, what is the cause of intermittent abdominal pain in patients of Peutz-Jeghers syndrome? Tell me. In patients of Peutz-Jeghers syndrome, very good. NEET PG 25, very good. It is intussusception because multiple polyps are there. What's the problem guys? Patient is having recurrent. The patient is having recurrent intussusception, and because of this recurrent intussusception, there is pain, there is occasional rectal bleeding also. Now, we are going to discuss most important questions related to Peutz-Jeghers syndrome. Can you see here? These patients are having hypermelanotic macules, and can you see the location? Lips, perioral region, buccal mucosa. So, it is lips, perioral region and buccal mucosa. All of you know that Peutz-Jeghers syndrome is autosomal dominant or recessive. Tell me guys, autosomal dominant. What is the most common site of What is the most common site of hamartomatous polyps? It is characterized by which polyp? Characterized by hamartomatous polyp. Hamartomatous polyp. Can anybody tell me what is the most common site? Obviously, it is S. S means small intestine, and in S, all of you know, in S, what it is? J. J means jejunum. So, in S, it is jejunum. Can anybody tell me what is the name of gene mutated? I am waiting for your reply. Anybody can tell me what is the name of gene mutated? Yes, Nazia, Nandu, Anuj, Twinkle, gene mutated. It is LKB1 or STK11. LKB1 or STK11 located on chromosome number 19. So, it is located on chromosome number 19. Easy. In this case, hamartomatous polyps are there. This question is asked in pathology. What are the special features of hamartomatous polyps in Peutz-Jeghers syndrome? You know, there is multiple branching, that is known as arborization. So, these patients are having arborization, and what else? Pseudo-invasion. So, patients are having arborization and pseudo-invasion. This patient is having risk factor for multiple malignancies, one of the most important, carcinoma pancreas. You know that for carcinoma pancreas, Peutz-Jeghers syndrome is having maximum risk. Peutz-Jeghers syndrome is having maximum risk, and since multiple polyps are there in small intestine, what happens? There is recurrent intussusception. So, it leads to recurrent intussusception. It leads to recurrent intussusception. These are important questions related to Peutz-Jeghers syndrome. Sometimes they give the picture of polyp. Which polyp? Hamartomatous polyp. Okay. Now, see the next one. Guys, see the next question. 5-year-old boy swallowed a disk battery, a button battery, and X-ray revealed that it was lodged in the esophagus. What is the next step in the management of this patient? Waiting for the reply. Tell me. Guys, tell me what's the correct answer. I am waiting for the reply. Yes, it is button battery. What is the dangers? What are the dangers with the button battery? You know, it contains lithium hydroxide. That's acid or alkali. Guys, that's alkali. Can anybody tell me which one is more dangerous, acid or alkali? Which one is more dangerous, guys, acid or alkali? So, it's alkali which is more dangerous, because alkali causes liquefactive necrosis. Alkali causes liquefactive necrosis, and if it causes liquefactive necrosis, if there is release of alkali from the battery, serial perforations are going to occur. So, as early as possible you have to remove the battery. As early as possible you are supposed to remove the battery. Now, see options. Very good. Twinkle, Om Prakash, Deepak, Shushu, Gamushi, Hanshu, Sheetal, Sarangi. Very good. Nandu, Suman. Okay. So, almost everybody is correct. Observation no. Immediate endoscopic removal. Endoscopic removal after 1 day of observation. No, guys, we are not going to observe. 2 days of observation. This is also incorrect. So, here there is button battery, disk battery. As soon as possible you have to remove it endoscopically, because there is alkali which can cause liquefactive necrosis. Correct answer is option B. Got it? Now, see the next one. Next. There is one famous question which is being circulated nowadays. Almost in each and every exam the questions are asked. These questions. First, the child is going to swallow the coin. Coin is in trachea, coin is in esophagus. How to identify? First, on the basis of symptoms. If the child is having dysphagia, what is the symptom, guys? The child is having dysphagia. It means the coin is in esophagus. You can see here. Whenever coin goes in esophagus, what happens? If you go for chest X-ray PA view, you can see this. This is chest X-ray PA view. Chest X-ray PA view. What will you find on PA view? You can see the patient is having flat surface of coin. So, on PA view, you can see the flat surface of coin. Can you see this? Flat surface. And if you go for lateral view, on the lateral view, you can see the edge. So, on the lateral view, you can see the edge. So, see, it's very easy to understand. Imagine this is a coin. This is how it goes into esophagus. So, when it goes like this into esophagus, if you go for PA view, you can see the flat surface, and if you go for lateral view, you can see the edge. Clear? In trachea, it goes like this. That's why on PA view, you can see the edge, and on lateral view, you can see the flat surface. Got it? So, I am repeating. In esophagus, coin goes like this. So, on PA view, flat surface, and you can see on lateral view, you can see the edge. In trachea, coin goes like this. That's why on PA view, you can see the edge, and on lateral view, you can see the flat surface. Got it? So, see here, guys, very easy. This is esophagus, and whenever coin goes in trachea, these patients are having dyspnea. What is the symptom? Patients are having dyspnea. So, one of the symptom is dyspnea. And here you can see this is chest X-ray PA view. On PA view you can notice that this is edge, and this one is lateral view. You can see lateral view, and on the lateral view you can see flat surface. On the lateral view you can see the flat surface. So nowadays these questions are very important, and these questions are asked frequently. These questions are asked frequently nowadays. Clear? Okay. Now see this. Hello guys, sorry for the disturbance. Now let's start again. See this question. I hope I'm audible and visible now. Hi guys, I think now I'm audible and visible. Now I think audible and visible. If I'm audible and visible, please. अच्छा. Hi guys, I hope now I'm audible and visible. Please send your thumbs up in the chat box if I'm audible and visible. There was some problem. So now see, okay. So I'm repeating the question again, okay. So 45 years old man reports experiencing bright red bleeding during bowel movements, and a mass protrudes from his anus, which he can manually reduce and does not reduce spontaneously. On exam, hemorrhoids are observed. Which degree of suffering from? patient is suffering from which degree of hemorrhoids, guys? So you know here what is first degree? In the first degree, patient is having bleeding. So in first degree, patient is having only bleeding PR. There is only bleeding PR in first degree. In second degree, apart from bleeding, there is prolapse with during defecation and so there is prolapse Hi guys, sorry for the delay because there was some internet issue. So let's start again from this question. A 45 years old man, we discussed this, patient experienced bright red bleeding during bowel movements. I am extremely sorry guys, and there is mass that protrudes from his anus which can manually reduce. He can manually reduce the mass and it does not reduce spontaneously. On examination, there is no thrombosed external hemorrhoid. Which degree of internal hemorrhoid is this patient suffering from? So everybody mark the correct answer, and that was third degree. We are going to discuss this again. So you know that what is first degree? In first degree, patient is having bleeding only. In first degree, the patient is having only bleeding. So there is only bleeding. In second degree, apart from bleeding, there is prolapse during defecation, and after defecation it goes inside spontaneously. So what happens? There is prolapse during defecation. The patient is having prolapse during defecation. Right? There is third degree. In third degree, there is bleeding plus prolapse, and patient has to put it back with fingers. It means there is manual reposition. So apart from bleeding, there is prolapse with manual reposition. Easy. Manual reposition. And fourth degree, guys, you know there is permanent prolapse. In fourth degree, there is permanent prolapse. You got it? So here, what is the correct answer? Here the correct answer is third degree. After that, some students were asking that, sir, what is the treatment? Let me discuss the treatment. If a patient is having first degree hemorrhoid, these patients are having constipation, just treat the constipation. So we advise high fiber diet and stool softness. Majority of patients are going to improve. Imagine patient is not going to improve. Patient is having first degree, second degree and selected patients of third degree. In these cases, we go for rubber band ligation or we go for sclerotherapy. So that is also known as rubber band ligation, that is also known as banding. Rubber band ligation, also known as banding or sclerotherapy, this is done for first degree, second degree and selected patients of third degree. But if significant amount of mass is coming out, in that case you have to excise the mass and you have to go for hemorrhoidectomy. For selected patients of third degree and for fourth degree patients, we are going for hemorrhoidectomy. And what are the types of hemorrhoidectomy, guys? You know, there is Milligan-Morgan, Milligan-Morgan open hemorrhoidectomy. There is Ferguson closed hemorrhoidectomy. Ferguson, this is open. Milligan-Morgan open hemorrhoidectomy, Ferguson closed hemorrhoidectomy. Whitefield submucosal hemorrhoidectomy and Longo-Stapler hemorrhoidectomy. Previously, we were doing Longo-Stapler hemorrhoidectomy, but nowadays Ferguson closed hemorrhoidectomy is preferred. Why? Because simultaneously you can treat external hemorrhoid also. So by this Ferguson closed hemorrhoidectomy, you can treat both internal as well as external hemorrhoidectomy. So you can treat both external as well as internal hemorrhoid. Okay, guys. So what is the correct answer here? Correct answer is option C. Right? Now see the next question. I am waiting for your reply. Which of the following characteristics is true regarding Meckel's diverticulum? Guys, tell me what is the correct answer. Anuj, Sushant, Shashank, NEET PG. Waiting for your reply, guys. Tell me, which of the following characteristics is true regarding Meckel's diverticulum? Waiting for your reply. So, you know that Meckel's diverticulum, it is characterized by rule of 2, seen in 2% population, located 2 feet proximal to IC junction. So, see the first option, it is located 30 centimeter, actually it is 60 centimeter. 2 feet proximal means it is located 60 centimeter, right? Okay. What is the length? 2 inches in length. So, length is 5 centimeter, that is 2 inches, and most of the symptomatic patients are less than 2 years of age. So, here option B, option A is incorrect. Option B, always lined with ectopic pancreatic tissue, it is incorrect. It is lined by ectopic tissues, but not always. So, what are those ectopic tissues, guys? How to remember? Mnemonic is GPC. How to remember? It is GPC. Can you tell me the full form? Full form bataiye aap log. What is the GPC? G means gastric, you know it is gastric, followed by pancreatic. So, it is gastric followed by pancreatic followed by colonic. So, it is GPC. Gastric followed by pancreatic followed by colonic. Next, it arises from mesenteric border. Actually, it arises from anti-mesenteric border. So, this is also incorrect, and contains all the layers of bowel wall. Yes, because it is true diverticulum, and true diverticulum contains all the 3 layers: mucosa, submucosa, muscularis propria. So, it contains all the 3 layers: mucosa plus submucosa plus muscularis propria. So, all 3 layers are there. Let us discuss the important questions, guys. Here the correct answer is option D. So, you can see this is how Meckel's diverticulum looks like. Can you tell me, this is along mesenteric aspect or anti-mesenteric border? First you can see anti-mesenteric border. Can you see, guys, this is anti-mesenteric border. All of you know that this is true diverticulum. Why it is known as true diverticulum? Because it contains all the 3 layers: mucosa, submucosa, muscularis propria. So, you can see this is mucosa, submucosa, muscularis propria, and we discussed that it contains ectopic tissues. And how to remember? Mnemonic is GPC. So, it is gastric followed by pancreatic followed by colonic. GPC. So, here is the tissue, and because of presence of this ectopic gastric mucosa, what is the problem? It is going to cause the ulcer, and since it is going to cause the ulcer in the ileum, can anybody tell me what is the most common manifestation? I am waiting for a reply. Guys, I am waiting for your reply. If patient is having ulcer, what is the most common manifestation? Yes, tell me. Obviously, it leads to bleeding. So, because of this, there is bleeding. This is the bleeding. Clear? How to make the diagnosis? You have to detect ectopic gastric mucosa. So, it's technetium per technete scan, and if patient is having diverticulum, patient is having this diverticulum with healthy base, in that case just excise the diverticulum, that is diverticulectomy. And if base is unhealthy, if the base is unhealthy, in that case we perform resection and anastomosis. So, base is unhealthy, in that case we go for resection and anastomosis. So, guys, almost everybody is correct. It's very, very important. In majority of cases you are getting image based question related to Meckel's diverticulum. Clear? Characterized by rule of 2. Now, see the next question. Let me see who is going to mark the correct answer here. Very easy question. Elderly male undergoes open splenectomy due to splenic rupture following a car accident. In post-operative room, he complains of shortness of breath and chest discomfort. What is the most common immediate complication after splenectomy? Okay, Mayank Malhotra, very good Mayank. Mayank, very good. Shovan's Mai, very good. CKA, very good. So, guys, see, it's very, very easy, straightforward question. What is the most common complication of splenectomy in post-operative period? You know, spleen is in relation to diaphragm. Whenever you are going to perform splenectomy, you are going to rupture or you are going to damage some fibers of diaphragm. So, in post-operative period, patient is having pain. That's why what happens? Patient is not having good respiration. In that case, what will happen? The ipsilateral lung is collapsed, and the name of that complication is atelectasis. If patient is not doing incentive spirometry, after some days what can happen? The patient might develop consolidation, patient might develop pleural effusion also. But the most common complication, that is atelectasis. So, remember this. Here the correct answer is atelectasis. So, this is the most common complication. This is most common complication. Okay. One question for all of you. Can anybody tell me what is the most common pancreas related complication of after splenectomy? Easy question for all of you guys. Tell me. Most common pancreas related complication. Waiting for your reply. Yes, Abhilash, Anuj, Priya, Sakti, Blake, Shashank, Skydogs, Himanshu, tell me. What is the most common pancreas related complication? So, most common pancreas related complication, guys, tell me. Very good. Okay, daily funny stuff, sir, आपकी salary कितनी है? Guys, it's good. Okay, now see what happens. See the relation. You can see this. This is pancreas, and you can see this is the spleen. So, you can see which part of pancreas is in close relation to the spleen, tail of pancreas. So, we are careful whenever we are performing the splenectomy. So, what happens first? These patients are going to develop acute pancreatitis. Most common pancreas related complication, it is acute pancreatitis. If a question is asked like this, that which part of pancreas is damaged, is the tail, because tail is in close relation. Tail is in close relation. Clear? So, it is acute pancreatitis, that is most common pancreas related complication. And can anybody tell me what is the most common late and fatal complication? I am waiting for your reply. Daily funny stuff, can you tell me what is the most common late and fatal complication? It's late and fatal. Yes, Abhishek, first person to reply correctly. Abhishek, you are absolutely correct. This is OPSI, and that is overwhelming post splenectomy infection. This is most common late and fatal complication. There is maximum risk of OPSI in the patients who are already having some disease. You know which one? Thalassemia. So, there is maximum risk of OPSI in the patients who are already having some disease like thalassemia or sickle cell anemia. And guys, you know that there is minimum risk of OPSI in the patients who are having trauma. So, after trauma there is minimum risk. After patient who are having thalassemia, sickle cell anemia, there is maximum risk. What is the problem? You know what is the function of spleen? It helps in phagocytosis of capsulated organisms. So, another easy question for all of you. Can you tell me what the most common organism responsible for OPSI? Most common organism responsible for OPSI. Santosh, tell me. Abhishek, Sushmita, Anuj, what is the most common organism? Obviously, it's a capsulated organism, and all of you know the answer. Guys, tell me, I'm waiting for your reply. First person to reply, Mayank Malhotra. Second person, Vivek Yadav. Very good. Guys, it is strep pneumoniae, also known as pneumococcus. Another organism is meningococcus, that is Neisseria meningitidis, and the third is Haemophilus influenza type B. So, which organism is responsible most commonly for OPSI? You know, strep pneumoniae. This is strep pneumoniae. So, strep pneumoniae. Clear? That's the most common organism. Neisseria meningitidis is another organism, and the third is Haemophilus influenza type B. And you know that, yes, it's easy to prevent, difficult to treat here. So, prevented by vaccination. So, we have to prevent it by vaccination. Now, see the next question, very easy. 70 years old female presents with sign of severe cholangitis. Despite initial treatment with broad spectrum antibiotics and unsuccessful ERCP attempt, her condition continued to worsen. Ultrasound shows multiple stones and a severely dilated CBD. What is the next best step? I am waiting for your reply. Let me see who is the genius over here. Patient is having cholangitis, not improving even after antibiotics. ERCP attempt unsuccessful. Ultrasound multiple stones, and there is severely dilated CBD. Severely dilated CBD. Yes. Till now, nobody marked the correct answer. Till now, only one person, Sushant Rawat. Only one person marked the correct answer, that is Sushant Rawat. And second, Gayatri Webb. Third, Dr. Murkan, Anu Sharma, Hanshu. Guys, see. What is the protocol? Let me tell you. Any patient who is having cholangitis, you know that it is characterized by a triad. What's the name of triad? It is Charcot's triad. You know, it is Charcot's triad. And what are the components of Charcot's triad? Pain, jaundice, fever. If there is delay in treatment, what will happen? It will convert into Reynolds pentad. It converts into Reynolds pentad. And what are the components of Reynolds pentad? Charcot strat plus shock plus mental status changes. It means whenever the patient is brought to your emergency, patient is in the state of shock and sepsis. You have to give IV fluids, you have to start IV antibiotics. Majority of patients are improving. If patient is not improving, in that case go for ERCP with stenting. If ERCP is failed, go for PTC. But see, PTC will be done when the problem is in the proximal part of bile duct. Proximal should be in the proximal part of bile duct. Here, problem is in the common bile duct. Where is the common bile duct, guys? You can see here. You can see. Here is the problem. Where is the stone? Stone is there in the CBD. This CBD is dilated. This hepatic duct is not dilated. It means mainly the problem is there in the CBD. If problem is in the proximal part of bile duct, you go for PTC. Distal part of bile duct, go for ERCP. But it is failed. So, we have another step. We have to open the CBD. And what is that? That is open biliary decompression. So, what we do? We open the CBD and insert the T-tube. So, it is open biliary decompression with T-tube repair. What we do? We go for open biliary decompression with T-tube repair. Right? And when you perform T-tube repair, after 7 to 10 days, you insert dye from this T-tube and perform T-tube cholangiogram. On T-tube cholangiogram, if distal filling defects are there, it means what? Still stones are there. Retain the T-tube for 4 to 6 weeks, and by Burheen's technique, we perform the percutaneous extraction. Which technique? Burheen's technique. So, here what we are supposed to do? Guys, here remember, whenever these kind of questions are asked, look that where is the problem. It is in the proximal part of hepatic duct or bile duct or common bile duct. So, here we go for open biliary decompression, repeat ERCP, no, PTC, no, continued observation and supportive care, no. So, after open biliary decompression, we perform T-tube cholangiogram on 7th to 10th day. On 7th to 10th day, easy. And if there are distal filling defects, retain the T-tube for 4 to 6 weeks, and after that percutaneous extraction of stone is done. And can you tell me how you are going for percutaneous extraction? The percutaneous extraction of stone is done by Burheen's technique. It is done by Burheen's. Clear, guys? So, it is done by Burheen's technique. So, percutaneous extraction of stone, it is done by Burheen's technique. So, it is very important, and let me tell you, I am telling you, bile duct is one of the favorite topic of INI-CET, especially bile duct injury, especially CBD stone cholangitis. So, you should be remembering all these important facts. Next question. Guys, this is very easy question. Let me see who is the genius over here. 45 years old woman presents with severe right upper quadrant pain. Another problem, she is having fever, there is nausea. She has history of pain after fatty meals, most probably suggestive of biliary colic. On examination, she has right upper quadrant tenderness. There is positive Murphy's sign. Guys, see this? Murphy's sign is positive, means patient is having acute cholecystitis. Laboratory tests show elevated ALP, bilirubin, transaminases, leukocytosis. Which investigation is best to confirm this diagnosis? Best to confirm, and almost everybody, Vivek Yadav, Abhishek, Elfirin, Himanshu, very good. C MBBS, Hanshu, almost everybody is marking correct answer. Guys, first, this patient is having acute cholecystitis. Acute cholecystitis, and all of you know what is the investigation of choice for diagnosis of acute cholecystitis. Investigation of choice, all of you know, this is ultrasound. And can you tell me what is the gold standard investigation? The gold standard is HIDA scan. What is the full form of HIDA? It is hepatobiliary immunodiacetic acid scan. So, it is HIDA scan, hepatobiliary immunodiacetic acid scan. And what is the finding? There is non-visualization of gallbladder. Let us discuss other options first. You can see option A, ultrasound sonography Murphy's sign is positive. True, it is positive, but it is not the best investigation. Option B, plain X-ray identifies radio opaque gallstone. It can identify, but this is not best. CT scan, there is pericholecystic fluid, impacted stone, gallbladder thickness. This is also correct, but this is not the best. What is best? All of you know what is best? HIDA. So HIDA scan, that's best. And guys, we are expecting that there might be some image based question related to HIDA scan. Normally what happens if you go for HIDA scan, there will be uptake in the liver, you are going to see gallbladder, you are going to see CBD, there is radio tracer in the small intestine. Normally there is radio tracer in gallbladder, CBD and small intestine. But what is the big problem in acute cholecystitis? First tell me, what is the initiating event in acute cholecystitis? Easy question for all of you. This is the gallbladder. And what is the problem? Here is the stone. So there is obstruction in the cystic duct. That's why this radio tracer will not enter into the gallbladder. And that's why in acute cholecystitis, you are not going to visualize the gallbladder. And this is the question. This is the favorite question of INI-CET people. Multiple times it was asked, non-filling of gallbladder. So there is non-visualization of gallbladder, but you can see tracer in CBD and small intestine. So this is the diagnostic criteria. What is the diagnostic criteria, guys? There is non-visualization. So you can see non-visualization of gallbladder or non-filling of gallbladder. Got it? So this is HIDA scan. Remember, it's the gold standard hepatobiliary immunodiacetic acid scan. Clear? Next. Very easy. A 55-year-old male patient presents with history of chronic hepatitis B. There is abdominal discomfort and patient is having weight loss. Imaging studies reveal a primary liver tumor. See, patient is having a liver tumor, risk factor is hepatitis B, and there are multiple metastatic lesions, right? Considering the typical metastatic pattern of liver tumors, what is the most likely site of these metastases? I am waiting for your reply. Let me see who is the genius over here. First person to reply correctly. I am waiting, guys, waiting. First person to reply correctly, Mayank, Maratiji, Tejashwini, yes, Deepak, Sushmita, Kav, Manta, Sheramani, Blue Blanket, yes, almost everyone. So let me explain this very easy. It's very easy to understand the metastasis, guys, very easy. Have a look. Can you see this liver? Can you see this is portal vein? This is inferior mesenteric vein. This is splenic vein. Guys, inferior mesenteric vein. This one is superior mesenteric vein. This is portal vein. And you can see this. This is left gastric vein, right? It forms portosystemic anastomosis with azygous vein. Clear? You know that GIT develops from foregut, midgut and hindgut, right? What is the blood supply of foregut? Celiac trunk. Midgut, superior mesenteric artery. Hindgut, inferior mesenteric artery. So if celiac trunk is there, celiac trunk means what are the branches of celiac trunk? Left gastric artery, splenic artery, common hepatic artery. So corresponding to arteries there are veins. Left gastric artery, so there is left gastric vein. Splenic artery, splenic vein. So what will happen? Via left gastric vein, via splenic vein, yes, everything is going to the portal vein and from portal vein to the liver. Via this inferior mesenteric vein and superior mesenteric vein means midgut and hindgut. Everything goes into portal vein and via portal vein it goes to the liver. So simple principle, any malignancy which is in the GIT from esophagus till rectum, any malignancy from esophagus till rectum having hematogenous spread. Can anybody tell me what is the most common site of metastasis? Yes, guys, tell me. GI malignancy from esophagus till rectum having hematogenous spread. What is the most common site of metastasis? Because the tumor emboli via hematogenous spread going directly or indirectly into portal vein and then liver. So for GI malignancies, it is liver. Now see the liver itself. Liver drains into hepatic vein. Via hepatic vein, it goes into IVC. So the tumor emboli from hepatic vein goes into IVC, from IVC right atrium, right ventricle and lungs. So the malignancies which are outside GIT and having hematogenous spread, in majority of those cases, the malignancy metastasizes to lungs. Classical example, CA oral cavity, carcinoma anal canal, RCC, HCC, hepatoblastoma, nephroblastoma, carcinoma penis, testicular tumors, soft tissue sarcoma. In all these cases, there is hematogenous spread and it goes to lungs. Got it? So it goes to lungs. So remember a simple principle, majority GI malignancies, hematogenous spread, it goes to liver. Most of non-GI malignancies having hematogenous spread, most common site of metastasis is lungs. Easy? So guys, the correct answer is lungs. Lungs. One easy question for all of you. Can anybody tell me what is the most common primary for metastasis to bone? कहाँ से आता है bones में metastasis. Tell me the malignancy. Guys, I am waiting for your reply. Guys, tell me. Very easy question. What is the most common primary for metastasis to bone? All of you know. Very good. Till now, nobody marked the answer correctly. Till now, nobody marked the answer correctly. I am waiting. Who is the genius over here? Nobody marked the correct answer. Nobody. Nobody till now. Guys, it's bone. What is the most common primary for metastasis to bone? It's not prostate. You are very close, but it's not most common. Think about females. Think about females. Nobody marked. Very, really very bad. Guys, think about females. Now tell me. In males, prostate. Obviously, in males it is prostate, but it's not most common. Till now, nobody marked the correct answer. Let me see who's the genius over here. Cervix. Dr. Strange. Very bad. I am waiting that who is the genius over here, and nobody till now. Nobody. Guys, which organ in females? Breast. First person, Sushmita. Very good, Sushmita. Breast cancer. Guys, in bones it comes from breast. So, most common primary for bone metastasis, what happened? It's breast cancer. Breast followed by CA prostate. It is breast followed by CA prostate. In Bailey, it's wrongly written prostate. In Bailey, it's wrongly written it's prostate. No, it's CA breast followed by CA prostate. It is breast. Yes, okay, Dr. Strange. So, it is breast followed by CA prostate. Next question for all of you. Now, this time, let me see who is going to reply first. Most common primary for brain metastasis. Anuj Sharma, okay, Anuj. Most common primary for brain metastasis. Another chance for all of you. I am looking at the screen. I am looking at the chat box. Most common primary. Yes, first person is Lalit Yadav. First person is Lalit. Second person is the pacemaker. Most common primary is CA lung. For brain metastasis, it is CA lung followed by CA breast. It is CA lung followed by CA breast. Next question. Let me see who is the genius over here. What is the most common primary for metastasis to kidney? Kidney. Let me see the genius. Yes, most common primary. Yes, very good. Sushmita again. Twinkle again. Very good, guys. It is CA lung. Carcinoma lung. Let me tell you, carcinoma lung is the most common primary for metastasis to 6 organs. What are those organs? Mnemonic is keypaps. Keypaps. It is keypaps. So, that's kidney. That's kidney. E, esophagus. P, pancreas. A, adrenal. B, brain. And S, skin. Brain, S, skin. Right. So, for kidney, esophagus, pancreas, adrenal, brain, skin, most common primary is carcinoma lung. So, guys, every year there will be 1 or 2 questions related to metastasis directly or indirectly, easy. So, these are the questions. Correct answer is option C. Next, very easy. A 65-year-old man presents with symptoms of jaundice and abdominal pain. Imaging studies reveal a solid mass where in the head of pancreas. So, it's very clear. Very clear. Histological examination shows dense fibrous stroma and neoplastic tubular gland. Extensive desmoplastic reaction, extensive fibrosis is there. There is neoplastic tubular gland. Tumor is characterized by local spread along nerves, lymphatics and blood vessels and has metastasized to liver. Most likely diagnosis. Most likely. Guys, tell me, what is the most likely diagnosis? First person to reply, Deepak, ORB. Deepak, ORB, Siddharth, Dr. Strange. Deepak, ORB, Siddharth, Dr. Strange. Only 3 people. Till now 3 people only. Then GYTRA. Okay, GYTR. Very good. Let me tell you. First, guys, if malignancy is there in the head, most probably it is adenocarcinoma. Second, there is jaundice also. Another feature of adenocarcinoma, there is extensive desmoplastic reaction. And what happens? There is neoplastic tubular gland. There is spread along nerves, lymphatic, blood vessels. So, this is ductal adenocarcinoma. Typically, ductal and adenocarcinoma, you know that the most common type of carcinoma pancreas. It's ductal adenocarcinoma arising from head. So, what is the correct answer? Head. Serous cyst adenoma, you know that this is cystic neoplasm. What will happen? There will be cystic neoplasm, and if you are going to aspirate, there will be cystic neoplasm, serous cyst adenoma. So, in this cystic neoplasm, what is the content, guys? Serous. Can anybody tell me, in serous cyst adenoma, amylase level will be normal or high? CEA, the tumor marker CEA, it will be normal or high? Easy question. So, obviously, there is no pancreatitis, that is why there is normal amylase or low, it is normal or low, and tumor marker is also normal or low, CEA. CEA. And if it is mucinous cystic neoplasm, obviously the content is mucinous, but this is pre-malignant here. There is raised CEA, amylase will be obviously normal or low. So, what is the correct answer here, guys? See, let me tell you, we are again expecting one question out of carcinoma pancreas, right, in this exam. So, correct answer is option C. Next question, very, very easy. Let me see who is going to reply first. 72 years old patient with BPH underwent transurethral resection of prostate under spinal anesthesia. After 1 hour, he developed vomiting and altered sensorium. The most probable cause. Easiest question. Easiest. Everybody is marking correct. Sushant, Nazia, Efrin, Abhishek, Sushmita, everybody, guys, you know that whenever the duration of surgery is more than 90 minutes, and whenever the size of prostate is more than 75 grams, because of extensive irrigation, there is absorption of irrigation fluid. Can you tell me what is the fluid used for irrigation of TURP? During TURP, the fluid used for irrigation, guys, you know. Can you tell me the answer? Guys, waiting. Tell me the answer. 1.5% glycine. So, it is 1.5% glycine. Because of overload of this fluid, patient develops TUR syndrome. It is TUR syndrome, which is also known as water intoxication, which is also known as dilutional hyponatremia. Because of hyponatremia, patient is having altered sensorium. Because of fluid overload, patient is having hypertension. Can anybody tell me drug of choice? In TUR syndrome, guys, can anybody tell me what's the drug of choice? Drug of choice? Yes, you know, you have to remove the excess fluid from the body. Mannitol, Dr. Strange, very bad. Yes, diuretics, obviously we give furosemide. We are giving furosemide, and guys, you know, even after furosemide, what happens? Still patient is symptomatic. It means still patient is having hyponatremia, and to correct hyponatremia, can anybody tell me which fluid should be given? Easiest question. To correct hyponatremia, which fluid should be given? I am waiting for your reply. Yes, tell me which fluid should be given if still patient is having hyponatremia? Obviously, we give 3% saline, and that is 3% saline means we are giving hypertonic saline. So, what we give, guys? We give hypertonic saline. Got it? So, here what is the correct answer? It is water intoxication. It is water intoxication, right? Water intoxication. Next, very easy question, again related to prostate. 78 years old man without medication, coexisting diseases, underwent TURP for BPH under spinal anesthesia with 2.5 ml of hyperbaric bupivacaine 0.5% extended to T10 level as tested by a pinprick, heart rate 85 beats per minute, BP 140 by 80, ECG is normal, SpO2 98%, means most of the findings are within normal limit. Patient was positioned in lithotomy posture, surgery was done successfully. Most common complication you are going to expect from the procedure. Obviously, this is what procedure, guys, TURP, majority of things are okay. So, can anybody tell me what is the most common complication of TURP? Easiest question. Everybody, Lalit, Shashank, CK, Sushmita, Sushant, everybody mark the correct answer, guys. After TURP, the most common complication is retrograde ejaculation. It is seen in 75%. After that, there is impotence. In what percentage you are going to see the impotence? Impotence is seen in erectile dysfunction or impotence. This is seen in 10%. And incontinence, that is seen in less than 1%. So, most common retrograde ejaculation. followed by impotence, followed by incontinence, and once this was asked long back in all India, what is the most common late complication of TURP? Late complication, and how to remember, mnemonic is bus. So, most common late complication, that is bus. Bus means bladder neck stenosis. So, it is bus, that is bladder neck stenosis. So, clear? It is bladder neck stenosis followed by urethral stricture. So, late complication, bladder neck stenosis followed by urethral stricture. Urethral stricture, easy. So, guys, what is the correct answer here? Correct answer is option B, that is option B, retrograde ejaculation. I sincerely apologize once again for that lag. Okay. So, guys, see again, next question, very easy. You can see 75 years old North Indian woman, see the age, 75 years, presented to OPD with complaints of fever since 1 month. Fever since 1 month, there is generalized weakness, anterior neck swelling since 4 years, but rapidly progressing since past 3-4 months, pain over the swelling and hoarseness of voice. Patient further reported history of weight loss and decreased appetite. She denied dysphagia, so no dysphagia, no dyspnea, and any history of cancer in the family. What is the most probable diagnosis? Very good, very good. Everybody is marking correct answer, guys. See, first, let me tell you the age. Can you tell me what's the age in papillary carcinoma? 3rd to 4th decade. 30 से 40. It is 3rd to 4th decade. What is the age in follicular and medullary? It is 6th decade, 60. And what is the age in anaplastic? 7th to 8th decade. 7th to 8th decade, right? Now, out of these 4, can you tell me which of the 2 are having sudden increase in size of swelling? So, there is follicular and anaplastic. Both follicular as well as anaplastic, these are having history of sudden increase in the size of swelling. In follicular, usually there is no pain over the swelling and there is no evidence of compression. No evidence of compression means the midline structures are not invaded. But what is the problem in anaplastic? There is severe pain over the swelling. Patient is having severe pain. So, there is severe pain over the swelling, right? Simultaneously, these patients are having evidence of compression because there is direct invasion of trachea. And if there is direct invasion of trachea, what's the problem? Dyspnea. There can be dysphagia. There can be hoarseness of voice. So, can you see the age? Can you see the symptom? There is weight loss, there is anorexia. So, all these are pointing towards anaplastic. Now, one question for all of you. Let me see who's the genius over here. Which thyroid malignancy metastasizes to bone? And in that malignancy, this kind of secondaries are there. This is pulsatile secondaries, matlab it's osteolytic and it's hypervascular. Waiting for your reply. Which thyroid malignancy is having pulsatile secondaries? Yes, pulsatile secondary. First person Naga Karthik. First person is Naga Karthik. Second is Sushmita. Very good. Follicular. Now, another question for all of you. Let me see this time who is going to mark the correct answer. Tell me what is the most common site of metastasis in follicular carcinoma? Which bone? Most common site of metastasis in follicular carcinoma, guys, tell me which bone. Waiting for your reply. Guys, Naga Karthik, it is not skull. No, it's not skull, guys, not skull. It's flat bone. I'm giving the hint. First person is Abhishek. First person is Abhishek. Thoracic vertebra. So, guys, follicular carcinoma goes to vertebra, followed by ribs, followed by pelvis, followed by skull. VRPS. Vertebra, ribs, pelvis, skull. VRPS. Which vertebra? Remember, thoracic vertebra. Which vertebra? It is thoracic vertebra. Easy. So, that's thoracic vertebra. So, here correct answer is option D. Now, see the next question. Very easy question and multiple times similar questions were asked in INI-CET. See, 19 years old female presented with progressively increasing midline swelling for 2 months. Neck examination revealed 3 cm into 2 cm into 2 cm swelling on the right side of neck extending from midline to anterior border of sternocleidomastoid. On palpation, it's firm and mobile. She has enlarged lymph node in the right level 2 and level 3, each measuring 1 cm. Most important, here calcitonin was raised 100 times. This is the clue. Just look for this clue. calcitonin was 100 times, swelling is from thyroid, there is lymph node metastasis, calcitonin is raised. All of the given below statements regarding diagnosis of above case are true except. So, you have to mark the false one. Guys, tell me what's the correct answer. False. Which one is false? Very good. Everybody is marking correct answer almost. Guys, this is medullary carcinoma thyroid. You know, it arises from parafollicular C cells. There is both hematogenous and lymphatic spread. It is TSH independent. That's why it is TSH independent. That's why this tumor doesn't take radioactive iodine. It doesn't take radioactive iodine, and most cases are sporadic. In how much percentage? In 80% cases it is sporadic, and in 20% you know it is familial. So, it is associated with MEN 2A 2B. That is why you know that this condition is associated with which this condition is means medullary carcinoma thyroid. It is associated with pheochromocytoma. Got it? So, what is the correct answer? Option C. It is TSH independent tumor. This is TSH independent tumor. Okay, guys. Now, see the next one. 45 years old female presented to OPD with history of weight gain, okay, decreased appetite, lethargy and weakness. Weight gain, decreased appetite, lethargy, weakness, all these signs and symptoms of hypothyroidism on laboratory investigation anti-TPO. You got the autoantibody. Which of the following malignancy risk is increased? So, first of all, can you tell me, guys? First of all, let me see who is going to mark the answer correctly. Till now only one person, that is Abhishek. Abhishek Pesra Meli. One person, only one person marked the correct answer. Abhishek Pesra Meli. Only one person. Now Dr. Murkan. Only two people. Only two people marked the correct answer. Guys, let me tell you, this is Hashimoto's. You know this is Hashimoto's thyroiditis. Hashimoto's. And what is the other name of Hashimoto's thyroiditis? You know this is also known as struma lymphomatosa. What is the name? Struma lymphomatosa. This is struma lymphomatosa. So, here there is conversion of thyroid tissue into lymphoid tissue. There is increased risk of lymphoma. Apart from, you can see here, there is lymphoma. Apart from lymphoma, there is increased risk of papillary carcinoma also. So, lymphoma and papillary carcinoma. This is autoimmune disorder. That is why there is autoantibody. Which one? Anti-TPO. That is why it is more common in females. It leads to permanent destruction of thyroid follicle. That is why the patients are going to develop permanent hypothyroidism. That is why the patients will be having signs and symptoms of hypothyroidism. How to treat? Lifelong you have to give levothyroxine. So, it increases the risk of papillary carcinoma, lymphoma. So, both A and C are correct. Correct answer is option D. Everybody is correct almost, guys. It's option D. Okay. Now, see the next question. Very easy question, guys. First you see this. What's the problem here? This patient is having winging of scapula. Winging. Now, see why. Patient is having papillary carcinoma of left breast. Patient came to your hospital for surgery after modified radical mastectomy MRM. Procedure was done on second post-operative day. Your rounds patient presents with following finding as shown in the figure below. Which nerve? Everybody is knowing the correct answer. Guys, tell me which nerve? Everybody knows the correct answer. It is because of injury of long thoracic nerve, and you know this long thoracic nerve supplies serratus anterior. So, this is winging of scapula. What's the diagnosis here? There is winging of scapula, there is injury of long thoracic nerve, and this nerve supplies serratus anterior. You know it supplies serratus anterior. Serratus anterior. Clear? So, it supplies serratus anterior. Correct, guys? Correct. Option B. Now, see the next question. Very, very easy. Let me see who is the genius over here. Though it's very easy question. 55 years old female presented with complaints of lump in the right breast. So, there is lump in right breast for the last 6 months, which progressively increased in size to reach present size. Physical examination revealed a mobile lump of 4 into 3 cm in right breast. Where exactly? Upper outer quadrant. On raising both hands of patient, what happens? Dimpling. So, what is noticed? Dimpling. Can you tell me? Dimpling is because of. So, this dimpling is because of involvement of, guys, till now Sushmita, Suryamani, Pallav, Upadhyay, very good, Sashank. Majority of you are marking correct answer, but not all of you. Let me tell you, some of you are obsessed with subdermal lymphatics, because there is involvement of subdermal lymphatics in pudy orange. In dimpling and puckering, there is involvement of ligament of Cooper. So, this is dimpling. Dimpling का मतलब होता है skin depression. You can see the skin depression, dimpling. Can you see? Clear? So, there is skin depression. So, this is dimpling. Dimpling, skin depression. It is because of involvement of ligament of Cooper. Not only dimpling, yes, here Dimple Kapoor, very good. Somebody is saying that sir, mnemonic is Dimple Kapadia, Dimple Kapoor, very good. Cooper's ligament. So, what happens? There is involvement of Cooper's ligament in dimpling and puckering. In dimpling and puckering, Cooper's ligament. So, here what is the correct answer, guys? Correct answer is option B. Option B. You can see this is the skin dimpling because of involvement of ligament of Cooper. So, dimpling, there is small depression over skin because of involvement of ligament of Cooper by the carcinoma. Puckering, again there is involvement of ligament of Cooper, there is wrinkling or small fold. Edema, that is pudy orange, it is because of lymphatic permeation or obstruction by the tumor emboli. And if patient is having cancer in cuirass, there is involvement of breast skin and chest wall. Breast skin and chest wall. Clear, guys? So, these are important questions. Now, see the next one. This is dimpling, how it looks like. Skin depression. Here this is puckering, wrinkling in the breast skin. In both of these, there is involvement of ligament of Cooper. Ligament of Cooper, and here you can see cancer in cuirass. There are multiple nodules and ulceration involving breast skin and chest wall. Got it? So, this is cancer in cuirass. Now, see the next question, very, very easy. Guys, tell me, which of the following statement is or are true about RCC? One by one we are going to discuss. First, renal masses appear as a tumor deformities distorting the renal outline or collecting system on IVB. Tell me, this is true or false? One by one, true or false? Tell me. First one is true or false? First, it is true. Most common mode of spread, it is not lymphatic, it is hematogenous. You know, it is not lymphatic, that is hematogenous. So, that is false. This is false. Next, there is Robson staging and Fuhrman grading in RCC, correct. RCC can present with anemia, hypertension and erythrocytosis. Yes, it can present with anemia, hypertension and erythrocytosis. Why? Because if a non-functional mass is there, there is decreased erythropoietin. If there is increased secretion of renin, so what will happen? There is hypertension, and if there is increased secretion of erythropoietin, there will be what? Erythrocytosis. So, this is also correct. Most common presentation of RCC is not the mass. The most common presentation is hematuria. So, most common presentation, that is hematuria. So, what is correct, guys? A is correct, C is correct, D is correct. Correct answer is option A. Option 1. So, A, C, D. It is option 1, ACD, that is correct. ACD, clear? So, it is ACD. Okay. Let us discuss the questions quickly. So, it is ACD. We discussed what is the most common route of spread? Hematogenous. Most common symptom? Hematuria. Lymphatic spread occurs only when the tumor extends beyond renal capsule, and the renal mass RCC, actually it is going to distort, it is going to distort the appearance. So, what happens? There are tumor deformities because of the renal masses distorting the renal outline or collecting system on IVP. Guys, this question is important, you have to remember the name, staging and grading. Can you tell me Robson staging, Fuhrman grading for RCC, Jackson, carcinoma penis, Gleason, CA prostate. So, what is common in all this? Sun. Can you see what is common? Robson, Jackson, Gleason. So, sun. Okay. So, it is sun. It is not the song sun. So, Robson, Jackson, Gleason related to urology, Robson for RCC, Jackson for carcinoma penis, and you know Gleason grading for CA prostate. Now, see the next question, very easy, very important, asked in pathology as well as in surgery. See this integrated question. 44 years old female was admitted to the hospital with 6 months history of progressive bloating sensation in abdomen. Bloating. The patient has a family history of tuberous sclerosis. Important clue is this tuberous sclerosis running on his maternal side. On palpation, mass was identified in left lateral abdominal area. Patient underwent an ultrasound. Hyperechoic mass 10 centimeter was identified in left abdominal area arising from left kidney. So, mass is in the kidney. CT, there is mass with mixed density 8 into 10 into 12. Lesion appear to arise from left kidney, okay, displacing the kidney to right. Biopsy was done and this is the marker. So, guys, it's a kidney tumor associated with, see the clues. First is a kidney tumor, marker is HMB45 associated with tuberous sclerosis. Can you tell me the diagnosis? Everybody is correct, everybody. Guys, it is angiomyolipoma. Angio means blood vessel, myo means muscle, lipoma means fat, more common in females, 6th decade, and you know it is associated with TS, tuberous sclerosis. The marker HMB45, sometimes there is macroaneurysm, and this macroaneurysm is going to rupture. Because of rupture of this aneurysm, patient is having retroperitoneal hemorrhage, and what is the name of that hemorrhage? That is known as Wunderlich. What is the name, guys? Name is Wunderlich syndrome. So, the name is Wunderlich syndrome. So, here the correct answer is option C. Option C is very important. If you see the CT, on CT you are going to see the presence of fat which is having minus 20 Hounsfield unit. Relatively it is black on the CT. So, it is a benign tumor. Option C is correct. Now, see this one, very easy. Let me tell you something about salivary gland tumors. Very easy question. Salivary gland tumors, see, estrogen is risk factor for salivary gland tumor, and if estrogen is a risk factor for salivary gland tumor, majority of salivary gland tumor are more common in females. Only one exception is there. Which one? Warthin's tumor. Warthin's tumor, that is also known as, first you tell me the answer, then I will discuss the question, guys. Tell me the answer. Answer, hot spot on technetium 99 is seen in which parotid tumor? Hot spot. Jasmine, very good. Himanshu, very good. Sushant, Rawat, very good. Guys, it is adenolymphoma. Why? Because what is the other name of Warthin's tumor? It is papillary cyst adenoma lymphomatosum, also known as adenolymphoma. Remember this. This is actually Warthin's tumor. Remember, this is Warthin's tumor. It is Warthin's tumor. And what is the other name of Warthin's tumor? Adenolymphoma, also known as papillary cyst adenoma lymphomatosum. Cyst adenoma lymphomatosum. Lymphomatosum. Okay. Why it is known as adenolymphoma? Because both epithelial and lymphoid components are there. I was telling that estrogen is a risk factor for most of the salivary gland tumors. That is why most of the salivary gland tumors are more common in females. Only one exception is there. Which one? Warthin's. Warthin's tumor exception. It is more common in males, remember. It is more common in smokers. It can be bilateral. Smokers, it can be bilateral. All salivary gland tumors give cold spot on technetium per technet scan. Only Warthin's tumor gives hot spot on technetium per technet scan. Only Warthin's tumor. Okay. So, only Warthin's tumor. Only Warthin's tumor, it shows hot spot. It shows hot spot. Clear? So, correct answer is yes, adenolymphoma. Clear? That is Warthin's tumor. Now, see this next question, guys. Choose the correct option. One by one we are going to discuss. Can you see the first one? Epidermoid carcinoma is the most common malignant tumor of salivary gland. Guys, it is not epidermoid, it is mucoepidermoid. This is muco. Excuse me. Mucoepidermoid carcinoma. So, first option is incorrect. Second, you can see mucoepidermoid carcinoma is the most common malignant tumor of salivary gland in children. Correct. Hemangioma, most common neoplasm of salivary gland in children. Correct. Adenoid cystic carcinoma, most common malignant tumor of minor salivary gland. And you know pleomorphic adenoma, that is the most common neoplasm of salivary gland. Clear? salivary gland. This is also correct. So, guys, you can see 1, 3, sorry, it's 2, 3 and 5. So, it is 2, 3, 5 which is correct, and almost everybody is marking correct answer. Everybody is correct. It is option A, 2, 3, 5. So, that is option A, 2, 3, 5. Okay. Now, see the next question, guys. Next, very easy. Let us discuss the options. Important questions related to salivary gland tumor. What is the most common neoplasm? Pleomorphic adenoma. We discussed most common malignant tumor of salivary gland, mucoepidermoid carcinoma. In children, most common neoplasm is hemangioma. Major salivary gland or most common malignant tumor of salivary gland in both children and adults, mucoepidermoid, and minor salivary gland tumor, most common malignant minor salivary gland tumor, that is adenoid cystic carcinoma. Easy. These are one-liners which are asked. Now, see the next one. Guys, tell me this easy question, what is the most common site of minor salivary gland tumor? Waiting for your reply. I am waiting for your reply. Okay, let me check who replied correctly. First person is Leela. Leela, after that Shashank, after that Gopinath, after that Anush Sharma. Anush, very good. Most of the times you are correct. Anush Sharma, MBBS C. Guys, what is the most common site of minor salivary gland? It's hard palate followed by sinonasal tract. It's hard palate. So, this is hard palate followed by sinonasal tract. Sinonasal tract. So, hard palate followed by sinonasal tract. So, it is palate. It is not the sublingual gland. Sublingual gland is already minor salivary gland. It is palate. So, it is palate. Okay. So, most common site we discussed, it is hard palate followed by sinonasal tract, and the malignancy we discussed, that is adenoid cystic carcinoma. Clear? So, minor salivary glands are mainly located in hard palate followed by sinonasal tract. Okay. Next question, guys. Very easy. Let me see who is going to mark the correct answer here. Male neonate born with omphalocele. This entity can be distinguished from gastroschisis because in an omphalocele the protrusion is. Very good, Dr. Goals. Reverse smoking, yes. If there is carcinoma hard palate, it is associated with reverse smoking, in which patient puts the burning end of bidi or cigarette in the mouth. You have seen in rural areas, especially in villages, people who are bidi smokers, they put burning end of bidi inside the mouth and they do like this. ठीक है, उसके बाद वो पीते हैं. It's very very dangerous because it increases the risk of carcinoma hard palate. So, here let's discuss one by one. Omphalocele, actually it's covered by sac, and there are two layers. Outside there is amnion, inside there is peritoneum. It's a defect in abdominal musculature. It's correct? Incorrect, because defect in abdominal musculature, splitting, that is gastroschisis. It is associated with intestinal atresia. That is also incorrect, because gastroschisis is associated with intestinal atresia and associated with congenital malformation. This is correct. It is correct, associated with congenital malformation. Got it? So, let us discuss, guys. Let me tell you, every year there is one question related to omphalocele and gastroschisis. Quickly, let us revise. So, here it is covered by two layers. What is the outer layer? You know, outer layer is amnion. Amnion, and what is the inner layer? Inner layer is peritoneum. So, outer layer amnion, inner layer is peritoneum. Peritoneum. So, amnion, that is outside, peritoneum is inside. So, how to remember, guys? Mnemonic is easy. Pin, mnemonic is pin, peritoneum is in. So, it is pin, pin. So, you can see this is omphalocele. This is associated with congenital abnormalities. That is why here the prognosis is poor. Here congenital abnormalities, most common congenital abnormalities, cardiovascular. In gastroschisis, it is on the right side of umbilical cord, bowel is exposed. Here there is increased risk of bowel related complications, but congenital malformations are rare. It is associated with intestinal atresia. Intestinal atresia. Nowadays questions are asked, let me tell you, the questions are asked on basis of treatment. How you treat it, just have a look. Imagine this is the part which is coming out. Suppose this is omphalocele, because it is covered, what you do? You reduce it, and after reducing it, go for primary closure. But if huge defect is there, in that case we apply escharotic agent on the sac so that it becomes thickened. If it's gastroschisis, again only some part of bowel is coming out, small defect is there, reduce it, go for primary closure. But if huge bowel is coming out, you have to cover it with a silo. So, silo placement, and we go for serial reduction. This is one of the famous question which is asked nowadays. Small defect, reduce it, close it, large defect, in that case cover the bowel with silo placement and go for serial reduction. So, this is omphalocele. Gastroschisis, in gastroschisis the prognosis is relatively good because it is not associated with congenital malformations. Okay. Now, see the next one. Guys, tell me what is the correct answer here. Read the question. 72 years old man. There is sudden onset of severe pain, numbness, coldness in the left leg. On examination, left leg appears pale. No pulse is palpable below femoral artery. Most probable cause is acute peripheral arterial occlusion. Most common cause. Everybody is correct. Let me tell you. In arterial disorders, any problem with artery, what is the main problem in artery? Yes, mainly there is occlusion. So, main problem in the artery is occlusion. And what is the important factor responsible for occlusion? That is atherosclerosis. That is why you are going to notice that in arterial disorders, for majority of cases, predisposing factor is atherosclerosis. Let me tell you where. Peripheral arterial occlusion, most common cause atherosclerosis. Most common degenerative disorder of vessel, atherosclerosis. Most common cause of subclavian artery stenosis, atherosclerosis, and most common cause of extracranial aneurysm or abdominal aortic aneurysm, atherosclerosis. So, here patient is having atherosclerosis. Suppose I am asking a simple question. Patient is young male smoker. Patient who is young male smoker. What is the cause of acute peripheral occlusion? Tell me. Young male smoker, age less than 40 years. Very good, guys. So, young male smoker, yes, in that case, Burgers. Remember, any patient who is having gangrene of toe, age is around 40, mark Burgers, but if age is around 60 or 70, mark atherosclerosis, because I have seen the students who are marking Burgers even if the age of patient is 70. Smoking increases the risk of atherosclerosis also. So, I am asking a question. 70 years old male, chronic smoker, having gangrene of one or two toes, cause atherosclerosis. 40 years old male, chronic smoker, gangrene of one or two toes, cause Burgers. So, remember the age. Okay, guys. Now, see the next one. Very easy question. Tell me what is the correct answer. A 55 years old woman presents with recurrent episodes of tender erythematous cord-like swelling along different superficial veins in the lower extremity over the past 3 months. Which of the following is most likely associated with this presentation? Patient is having migratory superficial thrombophlebitis. Can anybody tell me what is the name of this phenomena? Guys, I am waiting for your reply. If a patient is having migratory superficial thrombophlebitis, this is known as Troisier sign, Troisier syndrome, Troisier sign, Troisier sign, Troisier syndrome, Troisier sign. I am waiting for your reply. Tell me. Troisier sign, Troisier syndrome, Troisier sign. What is the name of this condition? Very good. Sushmita, most of the time, Sushmita, you are correct. Most of the times, guys, this is Troisier. This is Troisier's syndrome. What is Troisier sign? You know, the scarpopedal spasm in hypocalcemia, that is Troisier sign. What is Troisier sign? The supraclavicular lymphadenopathy in malignancy, that is Troisier sign. This node is known as Virchow's node. So, here, can you tell me what is the cause of this Troisier syndrome? Migratory superficial thrombophlebitis because of malignancy. It is because of malignancy. And can you tell me which malignancy? Guys, it is because of malignancy and most commonly associated malignancy. Tell me. Carcinoma pancreas. So, most commonly associated, yes, carcinoma pancreas. So, guys, what is the correct answer here? carcinoma pancreas, yeah, pancreatic malignancy. Got it? So, correct answer is option C. Okay. Now, see the next one, very easy. Very easy. Tell me what's the correct answer. 25 years old female, see the age 25, female, presents with swelling in right calf and foot, gradually worsened over the past 5 years. Swelling started in her teenage years and has become more pronounced with time. Diagnosis. Let me see who's the genius over here. Very good. Ankur, very good Ankur. Guys, everybody, almost everybody, somebody is marking B, somebody is marking C. Let me tell you, congenital lymphedema, all these are primary lymphedema. Congenital lymphedema is present at birth, obviously the child is less than 1 year. Lymphedema precox, this is the most common type of primary lymphedema. What's the age? 1 to 35 years. And a lymphedema tarda, age is more than 35 years. More than 35 years, easy. Congenital lymphedema is usually bilateral and there is involvement of what? Face, lower limb and genitalia, face, lower limb and genitalia, right. There is one question which is asked, familial version of congenital lymphedema is known as, let me tell you, congenital lymphedema, familial version of congenital lymphedema. Tell me guys, what is the correct answer? Yes. Familial version of congenital lymphedema is known as, tell me the name, I am waiting for the name, let me see who is going to reply. Familial version of congenital lymphedema, what is the name? Milroy's, very good. Anto Jindin, okay, Anto, it is Milroy's. Milroy's, this is frequently asked question. Milroy's disease. What happens in precox? It is more common in females, age 1 to 35 is the most common type of primary lymphedema. Here there is involvement of leg and foot. And the same question is asked here also, that familial version of lymphedema precox is known as, familial version of lymphedema precox is known as, tell me. Waiting for your reply guys. Familial version of lymphedema precox is known as, yes, Meeks disease. It's Meeks disease. Anybody can tell me what is Meeks syndrome? This is Meeks disease. So, can anybody tell me what is Meeks syndrome? Meeks syndrome, waiting for your reply guys, tell me. Meeks syndrome. Very good. Ovarian tumor, fibroma, ascites. Everybody is correct. So, guys, what is the correct answer here? It is lymphedema precox. Precox. Now, see the next question, very, very easy. Guys, tell me what's the correct answer here. 35 years old male presents to emergency department with complaints of extensive burns in his back, chest and legs. On examination, affected area are dry, leathery, charred, black, no blisters. So, there is charring, black colored leathery eschar. Yes, what is the most likely type of burn? Very easy question, very, very easy. So, since here there is no blister, there is dry, leathery, charred, black area, it means patient is having third degree burn. You know, first degree burn, that is known as epidermal burn. So, there is only involvement of epidermis. Second degree burn, it is also known as partial thickness burn. So, there is involvement of epidermis plus dermis. Third degree, it is full thickness burn. So, this is full thickness burn. Here, there is involvement of epidermis plus dermis plus subcutaneous fat. Subcutaneous fat, here you are going to notice black colored leathery eschar. There is no pain, no blisters, no pinprick sensation. And if there is circumferential eschar, in that case you go for escharotomy because it can increase the risk of compartment syndrome. And in third degree burn, healing occurs with contracture. What is fourth degree? Apart from skin, there is involvement of underlying structures like muscle, bone or brain. Like muscle, bone or brain. So, here what is the correct answer guys? It is third degree. It is third degree, straightforward. Sometimes they ask blisters are seen in which degree of burn? Second degree, which one? Yes, superficial partial thickness burn or deep partial thickness burn? Superficial partial thickness burn. So, these are the questions which are asked frequently. Yes, now see the next question. Let us discuss this. You told me that in first degree there is involvement of epidermis, second degree dermis, third subcutaneous fat, fourth degree muscle, bone or brain. Muscle, bone or brain, let me tell you the characteristic features. In third degree there is formation of leathery eschar, there is no pain, no blisters, no pinprick sensation. So, no blisters, no pain, no pinprick sensation, no PP, pinprick sensation. In second degree there is superficial partial thickness burn, superficial partial thickness burn, and there is deep partial thickness burn. Deep, in superficial partial thickness burn there is blisters. So, there are blisters in superficial partial thickness burn, clear guys. So, blisters are there in superficial partial thickness burn, right. So, these are important questions related to burns. Let me tell you, we are expecting one question related to pressure sore or pressure ulcer. Very easy to remember, whatever is the burn classification, it is almost same as pressure sore or pressure ulcer. So, first degree is stage 1. In stage 1 pressure ulcer, there is involvement of epidermis. In stage 2, there is involvement of epidermis plus dermis, means there is partial thickness skin loss. There is full thickness loss in stage 3. So, epidermis plus dermis plus subcutaneous tissue, and apart from what is seen in stage 4, apart from skin, there is involvement of underlying structure like muscle or bone. याद रहेगा आपको guys, याद रहेगा. I am again repeating, we are expecting one question in which sacrum will be exposed in the form of pressure ulcer. They will ask इसका stage बताइए, and obviously if you can see the muscle, if you can see the bone, it is stage 4. तो जो बर्न का क्लासिफिकेशन है, द सेम इज एप्लीकेबल फॉर प्रेशर सोर और प्रेशर अल्सर. प्रेशर सोर में एक आपको निमोनिक याद रखना है. व्हाट्स द मोस्ट कॉमन साइट? निमोनिक इज इंदिरा गांधी स्टेडियम. सो दैट्स इंदिरा गांधी स्टेडियम, दैट्स द साइट. इट इज ischium followed by greater trochanter followed by sacrum. So, it is Indira Gandhi Stadium. So, it is ischium followed by greater trochanter followed by sacrum. Okay guys, okay. Indira Gandhi Stadium, very good. Now, see the next one, very easy, and the similar question was asked last year in NEET PG. Patient with skin graft is experiencing mild swelling, oozing at the graft site 24 hours after surgery. Which phase of graft take is most likely occurring? Tell me. 24 hours after grafting, which phase? 24 hours after grafting. So, guys, it is imbibition, inosculation, revascularization, imbibition for the first 48 hours. It is for the first 48 hours. Here, the graft receives its nutrition by diffusion, that is imbibition, right. Inosculation, when capillaries are aligned together, when capillaries are aligned, that is inosculation, and this is complete by 4 to 5 days. So, capillaries are aligned together, and after 5 days, there is established arterial supply and venous drainage, that is known as revascularization. So, after 5 days established arterial supply and venous drainage, that is revascularization. So, here the correct answer is 24 hours imbibition. Everybody is correct, imbibition. Okay, next question guys, tell me what is the correct answer here. Very, very easy. 45 years old male undergoing damage control surgery. After sustaining severe abdominal injuries in construction accident, after rapid hemorrhage control, he is moved to ICU for further resuscitation. What is the main focus during ICU stage of damage control surgery? All of you know. What we do in ICU, there are 3 phases. Phase 1, control hemorrhage and contamination. Phase 2, shift the patient to ICU for 48 hours, and this is for secondary resuscitation. And phase 3, yes, we explore the abdomen again, definitive operation. So, it is not the definitive closure of abdomen, it is ongoing resuscitation and stabilization, it is not the repair, it is not the selection of next surgical procedure. What is the big problem? The patients who are unstable, they have trauma, triad of death. How to remember? Mnemonic is HCM. They have trauma, triad of death, that is hypothermia, coagulopathy, metabolic acidosis. So, hypothermia, coagulopathy, metabolic acidosis, we have to correct it after controlling hemorrhage and contamination. That is why we shift the patient to ICU. Guys, this is very important, especially in INI-CET. So, let us discuss quickly what are the phases. Phase 1, initial exploration. So, it is the rapid hemorrhage control and contamination. If there is hemorrhage, we go for ligation or packing. For contamination, if perforation is there, go for suture closure or segmental stapled resection. Phase 2 is secondary resuscitation. So, for how many hours we have to shift the patient? 48 hours, and we discussed we have to correct H. H means hypothermia. So, we have to correct hypothermia, coagulopathy, metabolic acidosis. So, it is HCM, and after that we have to shift the patient to OT for definitive operation. What we do? Planned re-exploration and definitive repair. This is one. They ask you the phases of damage control surgery. 1. Then they ask stages. What are the stages? 2 things you have to add. First, patient selection, and the 5th is abdominal closure. Rest of the things will be same. So, what are the stages, guys? You can see patient selection, stage 1, control hemorrhage and contamination, that is stage 2. Stage 3 is ICU resuscitation, shift the patient to ICU for 48 hours. Stage 4 is definitive operation, and what is stage 5, guys? Stage 5, abdominal closure. Clear? Okay, 2 options are there. 1, whenever you are thinking that patient might develop abdominal compartment syndrome, in that case you can keep the abdomen open. We are going to cover it with Bogota bag. It is just kind of mesh kind of thing is there. You are going to suture it to the abdominal wall, and sometimes you are going to close it. So, it is not always you are going to keep the abdomen open. Whenever there is risk of abdominal compartment syndrome, in those cases only we keep it open, right? Okay, now see this next one. Guys, every year you are going to get one question related to triage, right? See here, after major earthquake, a patient presents with compound fracture and spinal injuries. Considering the severity of these injuries and urgency of treatment, which triage color code is most appropriate? Waiting for your reply. Let me see who is the genius over here. Very, very easy, guys, very easy. Yes, Leela, very good Leela. Blake Blanket, very good. Som Subhra Das, very good. Sashank, almost everybody is marking the correct answer. Guys, see, in triage means to sort, and in triage what are the color codes? It's red, yellow, green, blue, black. Red means immediate care, immediate or emergency care because it's life threatening situation. Yellow means serious but not immediately life threatening. Compound fracture is serious. Spinal injury is serious but not immediately life threatening. Green, minor treatment is required. Blue, here patient is having extensive damage, and black, dead or moribund patient. So, the correct answer is B, yellow. Let us discuss triage. Guys, red. Red means emergency or immediate care should be provided. Why? Because this patient is having life threatening injuries. Patient is likely to survive if treatment is given early. Classical example you have to remember what? Patients who are having tension pneumothorax, massive hemothorax or EDH. So, patient can survive if we are going to perform ICD or we are going to drain it by burr hole EDH. Yellow means urgent care. Urgent, here patient is serious but not immediately life threatening injuries are there like compound fracture, degloving injury, visceral perforations. Non-urgent care, it is green, minor injuries. So, these patients are actually having simple fracture and minor laceration. Blue, blue here it is the 4th priority. These patients are having injuries like severe brain damage which requires extensive treatment and it exceeds the resources available. Black, patient is already dead or moribund patient. So, patient is already dead or moribund. So, what you have to remember? Yes, guys, you have to remember what? Emergency or immediate care for red, urgent for yellow, non-urgent for green, and expectant treatment for blue. Non-urgent for green, expectant for blue, and black is already dead, dead or moribund. I am repeating again, we are expecting one question out of this triage. Either red or yellow will be given, and since blue has been added recently, you might get a question about blue also. Blue also. Now, this question where majority of you are You are going to get the question and some of you are going to do the mistake. Read the question, guys. 45 years old male presents to emergency department after motor vehicle accident. He is tachypneic, has severe chest pain and paradoxical chest wall movement. Remember paradoxical. Oxygen saturation C 85%. Patient is having respiratory failure. A chest X-ray show multiple rib fractures on the left side. What is the most appropriate initial management since patient is having flail chest? Paradoxical chest wall movement. Flail. So, guys, it is flail chest. Can anybody tell me the definition? How many ribs at how many places? Fracture of how many ribs, how many places? Flail chest. Waiting for your reply, guys. How many ribs, how many places? Guys, according to the new definition, it's 3 or more than 3. Remember, it's new definition, 3 or more than 3 ribs. Remember, fractured at 2 or more than 2 places. 3 or more than 3 ribs, 3 or more than 3, continuous means contiguous. Okay. So, 3 or more than 3 continuous ribs, contiguous ribs, these are fractured at 2 or more than 2 places. This is the new definition. And whenever patient is having respiratory failure in flail chest, we give IPPV. And what is IPPV? All of you know, that is intermittent positive pressure ventilation. So, guys, what is the correct answer here? It's intermittent positive pressure ventilation. If patient is not having respiratory failure, in that case only oxygen inhalation, analgesia and physiotherapy, that is sufficient. So, this was all about this session, guys. Keep studying like this only. This Diwali, may God fulfill all your wishes. You are going to crack the exam with flying colors. Our best wishes are with you. We want that you should get the best ranks and the dream college as well as dream branch of your choice. All the best, guys. Keep working hard. Good luck and happy Diwali in advance.